So again, welcome everyone. Thank you all so much for joining us, for interviewing with us. We are honored to have you here, and we hope that the interview day went well. My name's Danny. I'm one of the current chief residents at our university hospital. I'm in charge of the medical ICUs and our cardiac ICUs. For our conference today, you are always welcome to participate. Feel free to participate via the chat, or you can talk out loud if you're an applicant, but do not feel like you have to. There is no secret mission here to see who participates. Ideally, you guys should just take this time off, enjoy the conference, and watch sort of how fantastic our residents are, and sort of see sort of what that training experience is like and how far and sort of how large a step you can take in just 6 months when you guys start here next year. So with that, I'm going to turn it over to our discussants and let each of them introduce themselves, starting with Jake.
Hey everyone, I'm Jake. I am a intern here in the hospitalist track. I'm originally from Boston, went to school at Rush in Chicago, which I don't think any of you are from, unfortunately. And just happy to be here with one of my best friends, Meg, and my first senior, Jess. Woo. Yeah.
The next Jess.
Yeah, I'm Jess, second year resident, also hospitalist track. Did med school here in Colorado. For that, Pacific Northwest and Southern California. Yeah, excited to join you guys today.
I'm Megan. I'm in the categorical track, but I have a lot of participation in the hospitalist track as well. I'm originally from Portland, Oregon, but I went to the University of Washington for med school and undergrad. So big dog, literally.
And I'm Sam. I'm a third year resident. I'm from Kansas City, and I went to University of Kansas for medical school.
Awesome. And Sam will be a chief here next year. So if you guys come here, you will get to work with Sam and all of these 4 of these residents a bunch. Okay. So again, huge welcome to all the applicants. Here's a list of everyone. We are super excited to have you all here. And so where are you guys coming from? This is a map. We have a bunch of people in the US, but today I think we also have 4 countries as well. So we've got Australia, the UK, Spain, and Puerto Rico. And again, so our residents are from all over, you guys are coming from all over, and we couldn't be happier to have you. So this is a picture I took this morning from the 10th floor of our MICU. So this is what you would see if you were in Denver today. And so we are facing towards the Rocky Mountains over here. This is the downtown. If you sort of imagine behind you is where our VA is by about half a mile. And then right there is where Denver Health is, which is our county sort of city hospital, similar to where a lot of you guys are probably trained in med school. And the case we'll be talking about today is going to be coming from our Denver Health urgent care. So it's a nice chance for us to work through something from basically presentation through diagnosis and management. So what's our conference teaching structure? So prior to the pandemic, we did everything in person and it was fantastic. We've made some changes since then. So now we do a daily virtual conference, which is what you guys are watching right now. In addition, we've done a lot of teaching in person in smaller groups. That's been cut down a little bit in the last couple of months as the numbers have gone up, but I think we'll get back to this in the near future. And then we post all of our daily conferences to our YouTube channel. And so just to, we're not tricking you guys. This is sort of how interactive and what our conferences are every day. And so if you want to watch any of our prior conferences, feel free to log on there. Some of my co-chiefs and residents have done just absolutely incredible talks, which I refer to back all the time. Okay, so with that, let's go ahead and get started. So for this conference, trying to sort of recreate the old kind of whiteboard noon conference, we're going to use an interactive whiteboard format here. So there we go. So for this conference, we're going to work through something, a patient who presented to the Denver Health Adult Urgent Care. For our applicants, that is a urgent care clinic, which is next to the ED in the first floor of Denver Health. It's a really nice opportunity because we can actually truly work through this person from the time they walk into triage all the way through diagnosis and management. So sort of an old school clinical diagnosis case. So for our discussants, let's get into it. We're going to be talking about a 34-year-old man. His chief complaint is 1 to 2 weeks of worsening chest pain and toe pain. HPI, so for 1 to 2 weeks prior to presentation, he developed chest pain and fatigue. Pain was initially generalized throughout his entire chest before localizing to the anterior chest 5 to 7 days ago. Pain is worse with any movement, improved when he's lying back. It's painful to touch his chest, and his left second toe has new pain in the last few days as well, which is worse with walking. 1 week prior to presentation, he developed bad breath, which he said in quotes, smelled like bad meat. He also had notable fevers and chills. He's got no past medical history, no surgical history, a couple family members with type 2 diabetes, and he does not take any medications. And with that, I will turn it over to our discussants.
All right, maybe I can start. So I guess the first thing I think, with this guy just coming, the first thing on top of my head is just sick or not sick. I live with 2 EM residents too, so I hear this every single day. But I think things I think about with this guy is initially this chest pain. So there are a few like esophageal causes of chest pain, there are cardiac causes of chest pain, and there are pulmonary causes of chest pain. And the reproducible nature immediately kind of rules out my like 7 or 8 don't miss diagnoses here. So I already feel a little reassured. And then just going through, the only thing that really jumps out to me immediately is when I hear bad breath that smells like bad meat. I guess from my med school days, I think of like Zenker diverticulum or something weird like that. And that's really as far as I can get with this so far.
Awesome. Any other thoughts from Jess or Megan?
Yeah, I mean, technically, people sometimes can have like stomach pains that can localize or be misperceived as chest pain. So never want to chalk it up to that, but could potentially be more like epigastric. Also, seems like there's something going on with his toe. His chest pain is not like anterior chest. I'm wondering if maybe he's got like pericarditis picture, making me think more cardiac again. But I think, like Jake said, his age and some of the qualifying characteristics of the history make it a little bit less concerning for like a cardiac etiology, but can't be ruled out right away.
Great. I think that's awesome. I think one of the 2 things that you guys did that was really perfect is, 6 months into intern year, so over halfway through, you're already sort of narrowing in on sick or not sick really early on, which is that really important distinction you need to make. And I think that was just a fantastic way to go about sick or not sick. I actually wanted to dive in a little bit more to something that Jake and Megan both brought up, which was how do we sort of clarify that chest pain differential? And so for any of the discussants, what methods do you guys have to figure out chest pain? What's your sort of schema for thinking about it?
I mean, I think off the top, first I go through like duration, exacerbating factors, kind of your typical, the quality and things like that. So for him, I would be curious if there's any pleuritic component as well. I think it's totally excluded in the STEM.
So you think about sort of exacerbating factors. Is there a pleuritic component? Sam, any additional thoughts?
Yeah, I agree. I think I usually ask about sort of cardiac features first. So like, is it exertional? Is it relieved by rest? And then I go sort of more into like, does it radiate? Thinking about dissection radiating into the back, or pleuritic component, or then positional things, like pericarditis classically better with sitting up and leaning forward.
Perfect. Yeah, I think that's great. And I think to be even a little bit more granular about this than like getting into causes. I heard this from one of our cards attendings as an intern, but a schema for thinking about chest pain is sort of this shooting an arrow schema. And so if I were to shoot an arrow at your chest, like what am I going to hit? So here's a cross-sectional CT that I pulled. And if you imagine this arrow going right straight through this person's chest, basically walking from top to bottom down. And so what are we going to hit? So the first thing we're going to hit, right, is we're going to hit skin and soft tissue. Below that, we're going to hit this person's pleura. Then we're going to hit a rib. Then we're going to hit sort of in combo, depending on where we shoot this arrow and how good our aim is, the lung and the heart. And then we're going to get a little bit further down. We're going to hit an esophagus, which is what Megan brought up, sort of referred things. Jake brought up that question of Zenkers as well. And then we get down all the way to the aorta in the back. And so all of you guys sort of touched on this, but just sort of putting a name to the schema, which you're already going through. Do you have any additional questions to clarify history before I give you a little bit more information?
Any dysphagia or odynophagia?
Yeah, great question, Sam. So no dysphagia, no odynophagia, but he has been eating less due to the chest pain, but he doesn't put that word on it. And why do you ask?
Just thinking about that, like bad breath, that was the first thing that crossed my mind. Like Jake said, is food getting stuck there and like essentially like a rotten smell from that.
Awesome. That's great. So yeah, right, narrowing in on like the 2 things. So you guys are focusing on the chest pain, the toe pain, and this kind of bad breath.
Any history of retching or nausea, vomiting?
Another good question. Yeah, so no retching, no nausea, no vomiting. Partly he thinks because he hasn't been eating as much, but he does give you this qualifier that maybe I could throw up right now. And then Jordan says, talked about the Series 6, great. Danny, one of our applicants, has an unexplained weight loss. Yeah, he's lost about 10 or 15 pounds in the last 2 to 3 weeks. And then Mike is asking if he's got any cough associated with fevers and chills. And said could consider anaerobic infection for the bad smell, which is great. Awesome. All right, let's give you guys a little bit more information. So,
Yeah.
all right.
Hey, there's one other question in the chat about what was the patient doing when the pain started?
Oh, good question. So he was at work as a cook about 3 weeks ago when he first noticed it. But he doesn't remember like a split second where it actually truly started. He sort of just remembered it during his shift and then it never really went away. Great question. So here's some social history. So he is born in El Salvador. He moved to Anaheim, California in 1999, lived in Anaheim for 2 months before moving to Colorado. He's traveled to Mexico and El Salvador in 2007. This case is happening in 2020, prior to the pandemic. He's a non-smoker. He doesn't drink. He doesn't use drugs. He's a cook and has been for 12 years. He's never been homeless. He's never been incarcerated, and he's got a dog at home. There are no birds involved in this story. All right, discussants.
Any inhalational, that was a little stretch, but any inhalational injuries as a cook?
Great question. Jess, why are you asking?
Thinking about, things that could tie his chest pain as well as his halitosis together.
Yeah, great. So no inhalational injuries, but a really good question to ask, right? So diving in more to that occupational history.
I think the biggest thing to ask, because this is Colorado and there hasn't been a Newton conference without this question, is how many birds does this man own or see daily?
He is bird free. So you ask him specifically and he says, I do not have a bird.
I mean, I feel like anytime someone is born outside of the United States or has traveled outside of the United States, they're always at risk for more rare infections that we don't see here, sometimes that we do. So, I mean, I don't know if this has like been a smoldering TB that would be causing chest pain, that would explain the toe, or if you could have any other kind of infection. Like I know, sometimes people come with schisto, which causes a lot of its own cardiac and pulmonary problems as well. So just things to think about on the back of our minds.
And just one other thing, I think one of our applicants already brought this up with like Chagas, we're starting to enter the realm of like multi-systemic disease. Like we could already maybe say this is some type of gastropulmonary process or gastrocardiac or something like that potentially. And I think this opens up a whole new world of diagnoses, especially during a noon conference. So.
Yeah.
That's great. And Jake, just to be really clear about it, why are you thinking multi-system disease with this history?
I'm mostly thinking this because this is noon conference, because I think common things being common, we have a better explanation.
Yeah.
But
including toe pain in the one-liners also makes me think that that's relevant.
Toe to chest.
Yeah, that's great. Yeah, right. You don't hear a lot of toe pain in the chief complaint, and I think we've got a lot of really good questions coming up, which we will all get to. So we'll talk about lymphadenopathy in the exam, but he does not report it. Dental health, he says that he has not seen a dentist in many years, does not have a standing dentist, but he does not tell you about any tooth pain. Fever history, he thinks maybe subjective. And then Emily, really excellent question, thought. So Emily's trying to tie together that poor dentition with possibly like an endocarditis and a septic emboli. So what Sam was saying was like, how can we tie together a chest pain and a toe? Like what connects our chest and our toe? And then Jordan says COVID toe. This is not COVID toe. Awesome. Any additional questions or thoughts on the social history?
How about any vaping?
Great question. So we will give you a no vaping as well. That is a really good question. And then
no drug use now or no drug use ever?
No drug use ever. So he is a non-drug user ever. He is a complete never smoker. And the last time he had a drink, he thinks was 15 to 20 years ago.
Wow.
Casey, one of the applicants, says sexual history. So he is sexually active with his wife and has been for a few years. No other partners. Shira, vaccination history, he does not remember and does not have any sort of records available. And then no family history of autoimmune disease. And CJ, unfortunately, he was not walking on any parasite-infested woods or streets. He did not step on any parasites. Okay, perfect. So what I want to do is for either Jake or Megan, go ahead and give us your one-liner right now sort of before we get into vitals and exam.
Can you go back to the history, please?
Yes, I will pull back up to the history. So there's your history right there.
Okay.
Sure. So I guess 34-year-old gentleman with no significant past medical history. I don't think it's relevant right now to maybe mention where he was born, but with coming in with about 1 to 2 weeks of positional chest pain, worse with movement, as well as left toe pain.
I think that's perfect. I think
And
that's
how-
I think that's great. Sam or Jess, anything to add to that?
No, I think all I said was and halitosis, but that's it. I'd maybe add the weight loss too.
Perfect. Yeah. So you guys are doing great, Megan. That was fantastic. So let's do this. So before we give a little bit more vitals and exam, what's your differential right now? We'll give you guys a top 3. You can go as specific or as broad as you want, and we'll come back and refine this as we go.
I would say if this was not noon conference still, GERD would probably be my number 1 thing.
Positional GERD?
I don't. It's,
actually,
it's a
yeah, I
34-year-old
mean-
guy. Maybe he was coughing and hurt his muscles. And then I guess with the travel history and stuff like that, I'd say infection, systemic infection. I don't know, stuff.
I don't know, I'm still kind of thinking like maybe some pericarditis. It's positional. It could be uremic pericarditis, and maybe it's like elevated uric acid.
And then maybe like autoimmune vascular. I mean, you literally, it encompasses everything always. So
Yeah, actually, that could also cause pericarditis too. Autoimmune things.
Great. I think that's great. And I think you guys didn't fall into that trap where you don't give like the most specific example possible early on, right? Because you don't have a ton of data yet and you don't have all the history. So I think that's nice, right? Putting things in big buckets and then working from there. So a really nice and thoughtful way to construct that. Okay. So let's go ahead and give you guys a little bit more history. So I'm going to go ahead and give you right now his vitals. So vitals when he walks into the AUC, which stands for our adult urgent care. So he is not febrile currently, but he says he was before walking in. His heart rate is 114. His blood pressure is 108/70. You don't have any prior blood pressures to compare that to. And he is satting 94% on room air. So pulling up this gentleman's physical exam, he is in no acute distress. He's got mild periodontal disease with no apparent abscess or lesion. So you might ask yourself, Danny, did you do a periodontal exam that well? I had an OMFS resident with me, which is an oral maxillofacial surgery resident, who was gracious enough to do a nice exam. Normal range of motion. He's tachycardic with no rubs or gallops. JVP is not elevated. Pulmonary. So notably, and I will highlight this for you guys because it's the abnormality. So he's very tender to palpation across his entire anterior chest. It's worse on the right. Decreased breath sounds in that right upper anterior lung field. And then when you go down to the MSK exam, he has left ankle tenderness, which he was not aware of until you pressed on it. He has significant pain with passive range of motion and that painful second toe with passive range of motion. So I'm going to throw this one back to our discussants.
I guess the one thing that I don't know kind of came to mind is with this periodontal disease, and multiple like locations of pain is something like maybe like Lemierre's disease or something like that, where you have septic emboli being thrown to either the pulmonary vasculature or other systemic vasculature. There's probably some exam finding that's a painful second toe that's specific to some disease process, but I am unaware of it unless it's like lymphedema. That's the only one I can come up with.
It seems like maybe something cartilaginous too, like just lateral to the sternum, like the ankle, the toe, pain with passive range of motion. Seems like a synovial issue or cartilage.
Yeah, I wasn't thinking Jake is convinced this is going to be something super zebra, but I have seen septic emboli thrown just from, your run-of-the-mill bacteremia, possible endocarditis, and people born in the United States. So I think that certainly kind of could potentially tie in the multiple joint pain with the lung chest pain. I think it's a little, I don't know, I feel like there's something about this right upper lung fields that's not usually the site of like a pneumonia or unless it's a, like TB or another sort of more unusual bug. And then I don't know if we have a skin exam. Like it seems odd that he has this chest pain all the way across. I guess you have some zoster.
What does that toe look like? Yeah, there we go.
So I will tell you, his skin exam is normal with the exception of this foot. So this is his left foot. This is his left ankle, and this is his left toe. And for the applicants who are asking, his joints are all warm, you think. They're definitely not cold, but they're not the warmest joints you've ever felt. And then no joint effusions, no history of easy bleeding while you guys are looking at the foot. Rheumatic heart disease, wonderful thought, like that. And then Emily, no skin findings. And then BMI, he is a BMI of 37, so he is considered obese. So what do you guys make of this foot?
I can't quite tell. Is that second digit, is it cool? Is it dusky?
It is slightly on the dusky side.
Where? Oh, yeah.
Are those
Any nodules on there?
those joints look a little large?
What are you thinking with that, Megan?
Dare I say, is that a tophi?
So there were no tophi, the joints are just swollen. And then when you sort of press in this, when you press in this area right here, he basically jumps off the bed. And then every time you try to flex his foot like that, he also jumps off the bed as well.
Mm.
It sounds like
Sounds like
tendonitis or the joint sheath there. Possibly.
And then some good questions. So is that area fluctuant? There is no fluctuance that you can palpate. And then Casey's saying it looks ischemic, which is great. Yeah, so that should be sort of one of the first thoughts as well.
And then Danny, like knees, elbows, shoulders are normal, right? And the other foot's normal.
Mm-hmm. Yep, knees, elbows, shoulders. The remainder of his joint exam is unremarkable.
I think Jess brought up a great point. I don't know if we heard it too, but like, is this a tendinosynovitis? Like, is this, and I never know how to say it, enthensinitis? And that would kind of support maybe just going back and reevaluating this autoimmune picture. And I forget the name of one of our incredible rheumatologists, but she emphasizes the hand exam, the hand fingernail exam might be huge for this guy potentially.
Yeah, great. So his hand exam is normal. So his hand and joints are normal. So in a true complete exam, he has absolutely no other abnormal joints. But that's a perfect thing to think about, right? You see one abnormal joint, try to find some others. Is there anything that any buzzwords that you guys associate with pain with passive range of motion?
like a septic joint.
Yeah, tell me more about that, Megan.
Well, I think that's always the thing that we worry about the most, and that would be like potentially a surgical emergency to have it washed out with ortho and to sort of save the joint from destruction of the infection. So I think that would be helpful to get them on board. Certainly with pain out of proportion to exam, like when we're examining soft tissue, we worry about like neck fascia, but that's obviously a slightly different part of the body, but
Yeah.
could potentially be the skin overlying that space as opposed to the actual joint. But I think with the passive range of motion pain, then you kind of worry more about the joint.
Perfect. I think that's a great way to think about it. So septic arthritis, neck fascia, and one of our applicants also brought up compartment syndrome as well. So that's sort of rounding out your differential for pain with passive range of motion. And for, I don't think I knew what this was when I was a medical student, but essentially if you rotate that joint through its full range of motion with your own hand, so no patient effort, if it causes pain, that suggests that there is pretty significant inflammation in that capsule and around the joint. And that is very, very specific for septic arthritis on your physical exam in the right clinical situation. Okay, so I heard you guys talk
and
about—
Danny, I just wanted to throw in there, you were talking about sick, not sick, and every once in a while you get these tweeners, and you get them in young people, like 37.6 isn't really a fever, and 114 isn't the worst tachycardia we've seen, and maybe he's 108 every day, but probably not, and 94% is not 95, so it is abnormal, but it's not that far off, and he's pan abnormal, and now he's got evidence of potentially necrotic end organ elements, right? Like digits and or joints that could be losing circulation. And so young people will do this. They'll fool us. You know, they look good until they don't is the classic, and then they fall off a cliff. So he's worrying me more as you give me more information.
Was it palpated on the DP?
Yes, you can palpate his DP, but when you asked about the dusky toe, that toe does feel maybe slightly cooler, but it's not the coldest toe you've ever felt.
I think also going back to what Dr. Connors was saying, just a slight tangent. I had this guy when I was a med student who was about same age, overweight, undiagnosed diabetes, so didn't know he had that. Came in with a infected pimple in his groin. His triage is like a 4 in the ED, which wasn't unusual. He didn't have, the only abnormality was tachycardia, and he ended up having Fournier's gangrene. So this could be that, and maybe he's a little immunosuppressed if he has some undiagnosed diabetes.
I like it. That's awesome. So Megan, so asking about undiagnosed diabetes. So let's go ahead and start getting into some objective data, because you guys have done a fantastic job so far. And this is basically, you guys are ahead of where I was when I was admitting this person. So you guys have brought up some really good points. What would you like in terms of, you're going to get your labs, you're going to get a CBC, a BMP, and LFTs. What additional imaging would you like for this person?
Neck ultrasound. I'm not going to let go of it.
Okay.
What about that joint? You have a surgical joint right there.
I want I said imaging. Yeah.
Jess,
I'd like it.
I mean, I think you'd start with X-rays. I mean, this probably warrants an MRI, but I would probably want to see his ankle brachial and toe brachial indexes first before a long MRI.
I think he's also bought himself a chest X-ray just based on the fact that we're considering septic etiology at this point. So I do a full infectious eval as well.
As long as I forgot.
awesome. You guys are, the X-ray tech is on their way while you are reviewing the labs. You're going to get a chest X-ray. You're going to get some X-rays of the foot. You are thinking about an MRI, but you want to wait for your radiographs first. Blood culture is perfect. So what are just to run through these labs real quick for everyone. White count's 14.4, hemoglobin's 12.9, 80% PMNs, 14% bands on that white count. Sodium is 124, glucose is 405, LFTs are normal. Any additional labs you guys would like?
Okay.
So not like 40.
We'll add that A1C on.
Oh, don't think that. I just mean undiagnosed.
A1C is 13.1%.
Nice.
Did we already get blood cultures?
Well done, Megan. Good call.
Mm.
Your blood culture
Actually stuck with me.
Sorry, did you say we already got blood cultures?
Blood cultures are pending.
You could do CRP.
Your CRP comes out to 100, and I'll go ahead and give you this as well. The trope was ordered, he's 0.02, so that's normal. And your procal is 4, which is high for DH. And a lactate is ordered because similar to Dr. Connors, there was some concern that this guy was a tweener, a now formal scientific term, and his lactate was 2.
Okay.
The CRP is interesting.
Tell me more about that.
I just think things that come to mind with stuff like this is with a value that high with a joint that doesn't look great, stuff like osteo. And then with a normal lactate, a bicarb that's, if anything, elevated, this doesn't seem like true septic physiology. And so it kind of, when I see CRPs and inflammatory markers that are that high, it also brings me back to our discussion of, autoimmune disease as well.
Also, okay, I had to double check, but again, going back to our pain out of proportion, they calculate the Ellernick score, the ortho loves that. And I just double checked because what I couldn't remember is if sodium was a part of that, and it is. So I just wonder if that could be a part of the workup too, is just calculating that score and sort of having that in the back pocket. Because I don't, Danny, you may know the sensitivity or specificity or how accurate that is, but maybe that would be helpful.
Yeah, great. So I was not planning on the Lorenic coming up today, but it's never a bad time to talk about the Lorenic score. So sensitivity and specificity are not great. And so neck fash is essentially a surgical diagnosis. You need a fascial biopsy in order to fully diagnose it, which usually requires being in the OR and seeing pus on between those fascial planes. So calculating a Lorenic is great. It's really hard to get a surgical consult without one. but it's completely a clinical diagnosis. So Megan, you're doing the right thing. Looking up the larynx is great, but even having that in your mind is the most important part when you're thinking about that. All right, I'm gonna start. Some imaging starts to roll in. While I'm pulling up the imaging here, Natalie, that CRP is high. The units are similar to the U. So I'm gonna give you guys a chest X-ray. So this is this gentleman's chest X-ray. You've got your PA on the left. You got your lateral on the right. And so I am going to ask either Jess or Jake or Megan to take a read at this.
You want to do it?
Oh, I don't care.
I talked a lot each year.
Sure. We could go through the whole ABC stuff, but I think we'll just jump to what we see in the right kind of mid upper lung field. A large circular mass. Maybe I can't quite make out if it's air fluid level or not. And then if that's pretty prominent lymphadenopathy as well, or hilar lymphadenopathy. There's a little bit, I don't know if it's just this screen, there's a little bit of reticular pattern as well, or kind of almost, well, I wouldn't say miliary, but if I had a good screen, a big screen, I think it might just be the screen.
And we can also consider our Aztecs here as well as always.
Jake, what are the Aztecs? Because you got the architect of Aztecs on the call.
Oh God! And of course, I don't know it perfectly, unfortunately, but I know it's something like ABPA. I think sarcoid, TB, edema, but that's the add-on one. The C could be anything. The S could be anything.
It's the first time I heard this.
Yeah.
Also, I don't know if that there's a little area on the right side in the hilum that looks a little more opaque. That's white. It's typically an area of a Gaunt complex. But I don't think that it would explain the large area that Jess was also talking about. So
Great. And then Sam, what are your thoughts on this lateral?
Oh yeah, I didn't look at the lateral.
Yeah, I think the lateral is interesting. The PA makes me think about it looks like a hilar mass, but then on the lateral, it's clearly very anterior. All of that anterior mediastinal space, it should be dark. It's just completely white, and so it seems more of like an anterior, almost maybe even mediastinal mass than a hilar mass. And then you do also see, I think I'm seeing spine sign there, what's in the posterior base.
Yeah, awesome. Sam, explain to me what the spine sign is.
So your spine should get more and more radiolucent on imaging on a lateral chest X-ray. And if it doesn't, like here, how there's that white spot at the bottom, you think about like a basilar posterior consolidation.
Yeah, that's fantastic. And so that's a really good way to describe it. And so it's one of our silhouette signs on the lateral. So you're losing both the silhouette of the vertebrae, and then you're sort of losing that diaphragm as well. So you can tell that this person probably has some sort of, most likely right lower lobe consolidation or infiltrate as well. All right, nice job. So what are you guys thinking? So we talked a little bit about diagnosis earlier.
Oh, Danny, can I just clarify before we go on? Because since I do love the Aztecs, it tends to be for upper lobe cavitary disease. And it's often bilateral. So it's never a bad time to think about it because that thing could cavitate. So just to keep that in mind. And then I totally agree with Sam. This is an anterior mediastinal mass. There is something bulging out there, but that anterior mediastinum is entirely, it's very homogeneous. It is a white triangle in there, and that should all be dark in color. And what you see making that spine sign, whenever you see a spine sign, you then go back to the AP or PA and you want to look and see, well, where the heck was that thing? And it's actually, I think, what's in the right diaphragm. So if you follow your right diaphragm out, it's got a pretty good costophrenic angle and cardiophrenic angle, but somewhere in the middle, 2/3 out to the periphery, it hazes out. Yeah, exactly. And there's a little bit of, I think, what Jess was hinting at, a reticulation above that. It's a classic overcall area because there's so much vasculature there. But when you see that haziness and you lose a bit of the diaphragm and you got your spine sign, then I think you can say with more certainty that there's some sort of an infiltrate there. And we don't look at a ton of laterals, but look at that airway and esophagus on the lateral. They are so well demarcated. They're really usually trying to debate where the heck they exist. There's a lot of stuff surrounding them, which is what makes that air stand out so well.
Awesome. Thank you, Dr. Patterson. There will be more chest in as well, so don't lose hope. All right, so you guys get this chest X-ray while you're standing in the person's room. Jordan's bringing up that sort of anterior mediastinal mass differential, which is great. We'll talk about that more in a second here. So what do you guys want next? I'll tell you the X-rays of the foot were normal.
CT.
All right, so you're going to grab a CT of the chest. And so what do you want first? Would you prefer to have his mediastinal windows or his lung windows?
I'm a sucker for the long windows.
I usually look at mediastinal windows first, just as my sister.
We'll defer to,
I don't think that's right. It's just how I do it.
we'll defer to seniority here. So this is his mediastinal windows. And I'm going to play this a couple times for you guys to look at.
Dang.
Oh.
All right, so I'm gonna play that one more time. And then I want people to throw in the chat what abnormalities you're seeing while we let our discussants look through this a couple times.
Yeah. there's-
I think so, yeah.
All right, let's play that one more time here, and then we will, I'm gonna ask Sam to give me kind of her biggest abnormalities. All right, Sam, what are you seeing?
So I see that mass on the right side, anterior, I'll call it like a, I guess, anterior right upper lobe mass, and it almost looks like fluid density inside with a little bit of air there. So making me wonder, is that an abscess with a little bit of necrosis? It doesn't look clearly solid, I would say, or maybe it's just heterogeneous and solid. And then there's also a small right pleural effusion. I was trying to see if I could appreciate any hilar adenopathy, and I don't at least see any like bulky adenopathy. It's going a little fast, but I don't see anything.
Great, Sam, that's a perfect read. Yeah, so you see this mass, you see some air in there, which is perfect. You are on the correct path. I'm going to go ahead and push this to, yeah, so UCH is saying a rind-covered mass that's homogeneous that looks infectious. Great. I'm going to push this to Dr. Connors. Dr. Connors, what do you see in the CT?
Yeah, I agree with Sam. Not anterior mediastinum. I was wrong. It is in that right upper lobe for sure. It is very homogeneous. There's the little bit of air bubbling in there. And then the thing that's the most concerning is if you look just outside of his ribs, that same air exists. And if Danny wants to scroll up and down a half second there, yeah, I mean, whatever is in his chest is actually growing through and or spreading through the chest wall itself. And so certainly explains his discomfort. You can then, when you see that, you can see all the edema and swelling there. And I agree, we can check out his lung windows. And you're right, Sam, there's your area. Danny's got you set up to look for lymph nodes, right? So you go to where the aortic arch is complete, neither ascending nor descending, and there should just be the arch, the esophagus, and the SVC. And anything else that isn't that is a lymph node, although here we do have a burp in his esophagus, so we can see that. But in that triangle between those three structures, there's some necrotic lymph nodes. And I think that's what they'll call them as moderate size necrotic lymphadenopathy.
Yeah, awesome. And so between the discussants and Dr. Connors, that was a perfect read. So I'm gonna go ahead and show you his lung windows as well. And then we will come back and give you the complete read of this after the lung windows. And I will play that for you all one more time. And then we'll go to the Jess, Jake, Megan combo for just giving me the biggest abnormality that you see on the lung window, or lung abnormalities, plural. All right, so what are you guys looking at?
There's some peripheral dense consolidations there on the left. Looks like the parenchyma is like relatively well preserved, and don't see any like bronchiectasis or any other, I don't know, particularly striking features right now. There was also some like basilar ground glass opacities as well that we saw later.
Awesome. So Jake, what do you, if you were going to put a name to these imaging abnormalities, what would you say?
Yeah, I guess I would say, left middle lobe, peripheral dense consolidations.
And Sam, does that sort of ring any alarm bells in your head or clue you into any diagnoses?
I mean, yeah, I would call them like relatively like small consolidative opacities. I'm thinking like, are these septic emboli? And I thought even lower down that maybe I saw a couple small cavities, but maybe I didn't. And so that especially worries me for something like septic emboli.
You did indeed see that. So let's go back. So you guys both read that perfectly. So Jake, awesome job. Those are septic emboli. And so your formal official read is a 7.2 by 6.5 centimeter right upper lobe cavitary lesion with fluid extending through the intercostal spaces into the pec minor, with also some concerning involvement of the second and third rib and osteomyelitis of the first rib. So you guys are now told that there is an abscess here, or a lung abscess or fluid collection, extending into the first rib and sort of out of the pleural space. Does that give you, is that a diagnosis for you guys? Do you guys know sort of what we call that medically?
I believe that is called empyema necessitans.
That is absolutely correct. So Jake, what can you tell me about empyema necessitans?
Not a whole lot besides that word. But my understanding of it is essentially an empyema that has then crossed the chest wall and makes essentially, my brief understanding is essentially complicates treatment then more than anything else.
Yeah, that's absolutely amazing. So it's essentially an empyema that is eroded through that chest wall and out of the pleura. And it's a pretty uncommon diagnosis. We don't see it a lot because typically, right, we treat people for pneumonias and we treat them for empyema before it has a chance to erode out. But this gentleman on the official CT read is called that he has an empyema necessitans of his right upper lobe. So what I want people to do now is in the chat, I want you guys to throw out what you think might be causing this gentleman's empyema necessitans. So give me sort of what his etiology is, like what bug you're looking for about the next 15 seconds. Then I will ask our discussants for bugs as well.
Danny, in retrospect, could you see any of this or feel any of this in the patient's chest wall?
Yeah, Sam, great question. So not on the day of diagnosis. The spoiler is that you eventually could feel a bump by sort of a few days after hospitalization, but he was very tender over that area, but there was no clear skin defect. All right, so we're seeing nocardia. You guys are good. Anaerobe, staph, nocardia, gram-negative, actinomyces, TB, strep milleri, staph, indolent infection. A lot of applicants know a lot about empyema necessitans, which is great. So the teaching point here, you guys all did fantastic. So it's sort of an esoteric diagnosis. We don't see it a bunch. And so one of the sort of more helpful ways to think about empyema necessitans is to think about sort of what's our differential diagnosis for things that cross tissue planes. So essentially, what is our diagnosis for infection or an illness that goes across a tissue plane into another space? Because that's essentially what we're working with here, is an infection that's crossing from the pleura into the chest wall. And so one of the things you guys did, which was great, is you were all already doing this, but you were putting things in buckets. And so one of our buckets is going to be mycobacterial. We've got a regular bacterial bucket, fungal, and then one of our mimics, which is going to be malignancy. And so between these four things, you can sort of create a differential for things that cross tissue planes and empyema necessitans. And so the person who mentioned TB is correct. So the number one cause in the world is going to be TB. The number two cause is going to be actinomyces. After actinomyces and the rest of the bacterial stuff, you get into staph, you get into strep, particularly strep anginosus, which is one of our streps that behaves like staph. It's a strep that likes to form abscesses. And then you get into nocardia as well, and some sort of weirder ones. Fungal, you are going to see most commonly blasto being the cause of this, depending on where you are in sort of the endemic region. And then aspergillosis. And then when you're talking malignancy in the chest, this is going to be, your primary lung cancers, but then also classically lymphoma as well, eroding through the chest wall. And so just to hammer home, if you are seeing this in a person with the correct risk factors, your first thought should be TB, and probably second thought should be actinomyces for etiologic agent. Dr. Connors, any additional thoughts on empyema necessitans and how sort of to think about diagnosis?
No, I don't. This is excellent. And when I saw those, when I saw people putting nocardia and actino in there, I knew you guys were on top of this. The only thing I'll add is that when people come in and they start describing longstanding symptoms, you do have to think about multi-infectious organisms. So a lot of these trapped infections, if we think that they may have started in the mouth, they may be have multiple different bacteria in there. So narrowing too quickly is the only thing I'll just throw out not to do.
Awesome. That's perfect. Yeah. So consider co-infection. And Dr. Connors, of course, in his knowledge is very prescient because I'm going to give you guys a bug now. So you ordered blood cultures the second you saw this person, and their blood cultures come back with group B strep, which notably, right, is not a thing that we just talked about because group B strep is not a common cause of empyema necessitans. So for our discussants, and Megan in particular, why does this gentleman have group B strep?
I mean, it could be the diabetes and that he's like relatively immunosuppressed.
Yeah, that's perfect. So you called this right away, right? You were thinking about comorbidities and other factors that predisposed him to illness, and his risk factor is diabetes. And so diabetes is probably the largest risk factor for non-pregnant adults to get a group B strep infection. And so the fact that this gentleman has horribly uncontrolled diabetes has definitely predisposed him to this. So really nice job. So in addition, you also got cultures of a bunch of other stuff, including the ankle, and then an aspiration of this as well. And like what Dr. Connors had talked about, he grows out MSSA from the empyema on his chest. He grows out VRE from his foot aspirate. And then he also grows out an anaerobe as well, which was unspecified. So he ends up having a polymicrobial septic arthritis of the ankle and a group B strep, predominantly empyema necessitans. So how do you guys want to treat this guy? Who do you want to call, or what do you want to do?
Everyone.
I mean, we need source control of that empyema, but now it's like outside of the lungs and it's in the chest wall. So like maybe CT surgery, but then ortho for the ankle, ID, absolutely.
Awesome. Yeah, so you guys did the exact right thing. So you called 3 separate services like you talked about. You called ID, which recommended we'll talk about in a second. You called podiatry, which is our go-to for sort of below ankle amputations and care at Denver Health. And then you called CT surgery, which at Denver Health as well as our TACS team, our trauma and acute care. And so what did they end up doing for this gentleman? So he had an ankle washout, which is what you're seeing here. And then he ended up having his second toe amputated because he was found to have pretty destructive osteomyelitis of that toe. He also had a small abscess here, which was not apparent on clinical exam, which was washed out as well. And then on the left image, you're seeing this humongous incision here. So he ended up going for a right lateral thoracotomy and had his a lot of pus evacuated from the fascial and muscular layers of his chest. But ultimately, he did not require, if you notice up here, any sort of chest wall reconstruction. They were able to evacuate about 500 cc's of pus out, and the combination of antibiotics and evacuating pus gave him this chest x-ray at 1 month follow-up. And so he ultimately did really, really well over the long term and is still doing okay today. And then sort of the other nice thing about this is, and for our, so Snehal, was this his first interaction with the healthcare system? You're like a plant in the audience. It absolutely was. And the nice thing was that Yunan, one of our second year residents who was taking care of him on his team, basically offered to be his PCP while she was his inpatient provider. And so he established with one of our second year residents prior to discharge and has been receiving sort of primary care sort of with our resident group since then. And he's doing significantly better. So applicants, this, I think, this case really shows off cool stuff we take care of in our hospitals, and then really, how fantastic our residents are at sort of diagnosis and management. And just to make this a little bit more esoteric, I was just going to give one more teaching point on empyema. And so empyema, it was first talked about in this Hippocratic corpus. So we had a grand rounds about some medical history this week, but this is an old school diagnosis. Interestingly, it was not thought to be a primary disease then, but an inability of the physician to cure an existing illness of the thorax, which sort of makes sense, right? We know now that if we don't cure your empyema, it'll get worse, or if we don't cure your pneumonia or your parapneumonic diffusion, it might get worse. But Hippocrates and his students figured this out as well. Their mechanism was sort of even more interesting, was stagnation of fluid, so concretion, so that fluid got thicker, which then became your empyema. And their sort of diagnostic strategy was they shook the patient and they listened for the sound of fluid. And then they looked at the chest and saw which side was more swollen. And then the treatment, this is the part that really got me. So the vapor bath, I think, might be the earliest recorded instance of chest PT. So they basically had these people inhale like a weird milk wine combo and then just shook them until they coughed and expectorated pus. And if that didn't work, they did thoracostomy and drainage. And so I think what you guys are all thinking right now is, Danny, what did that thoracostomy look like? And I know this is a lot of words, but I'm just going to highlight the notable parts. So they cut the skin below the ribs, the bellied scalpel, they wrapped the lancet in cloth, and they basically shoved it in until they could expectorate pus. After that was done, they plugged the wound with a tent of raw lemon, tied it with a cord, and sort of similar to our chest tube kits now, they would just draw off pus once a day, and then they would plug it with linen. And then they would do an infusion of warm wine and oil with a tube, which might have been the early MIST-2 trial. So before we had lytics, we would just put warm wine and oil into your chest. And then, the interesting thing is when the cavity was completely dried out, they cut off the little tube and let the ulcer unite before removing it. And so really old school way of source control, and shows that, even in 2000 years, we're not extremely far off from where we were back then. And so that's it. I think it was a great case. It was a really great teaching case because I'd never heard of empyema necessitans. And I'd be interested to hear from our discussants if you guys have any thoughts or sort of recollections or feedback on this patient.
Sure.
You go for it.
Oh, it's just I'm always surprised by young people's diagnoses like this. Like I was so impressed when Meg immediately brought up the diabetes issue, and it was not even close to being on my radar. And I think this is someone I might have seen if I had been the ED and been like, you should go home. And it's good that other people work this gentleman up better than I would have.
I mean, empyema necessitans, I literally have never heard that word. So that's probably my takeaway from today. Yeah, pretty interesting.
I'm also just impressed that he recovered as well as he did. I mean, that's really impressive with good care. And yeah, similar to Megan, it's a new diagnosis.
Pretty good, Jake.
Thanks, bud.
Awesome. Well, again, Discussants, thank you guys so much for participating. You guys did fantastic. That was awesome. And applicants, if you want to be as good as these guys are in about a year, you should absolutely come here because I think our clinical training is amazing, and it's just fun to work with all these people on a daily basis. So thank you all. Residents, thank you for participating, and have a wonderful rest of the day.
Thanks, Danny. Thanks, applicants.
Yeah, thanks, Danny. A great case, and to everyone who did that case, thank you. I know it's uncomfortable to do a cold case in front of 90 people, so I appreciate it. You guys are great. I think you're awesome.